first, before we move forward, I want to, as I always do, want to thank the office of Dr. Vladimir Krasinski and his wife Ella Krasinski, who feeds my passion and my soul and love for holistic dentistry. I started back in 1984. Yes, I'm an old woman, as they had said. And now my passion is running really deep, and they're feeding my soul, and I want to thank them deeply. Now, to start, I'm sure everybody knows what this is. This is the patient you're seeing right before lunch or at the end of your day, especially on a Friday, okay? These are your patients that show up highly inflamed, lots of plaque, gingivitis, and periodontal disease. Now, there's different ways of treating this, whether you're in allopathic or conventional office, or if you're in a biological practice, and that's what we're going to talk about today. I am not going to be giving you any specific protocols to follow, but I am going to make suggestions that you're going to incorporate into your practices, because every practice is different, but the basis is the same. It's about treating the whole of the patient, not just between the nose and the chin, okay? Believe it or not, the mouth is attached to the body. I come from the generation where the two was a complete disconnect, and they were only treating the teeth and the gums, bill, drill, and fill, and send the patient home. Now we know that it is extremely important to treat the body systemically, and that's where the whole oral systemic dentistry is now becoming very popular in the conventional world. My son hates when I say this, but we are the OG of oral systemic dentistry. We've been doing it since 1979, and they're just doing it the past few years, so, you know, it's time to catch up. Why is Pareo so important to talk about? We have at least a minimum of 50% of our American population has some form of periodontal disease, whether it be early gingivitis up to advanced stage perio. Other statistics show it could be 80 to 90% of the population, which I believe is more accurate, but this is coming from the CDC. Now we know, again, this is another course, not by me, that all the systemic problems that can arise from periodontal conditions and vice versa. It is a bidirectional issue, okay? Patients who have diabetes can have, inflammatory issues, et cetera, et cetera. So that's why we want to talk about it. Now, if we're talking about perio, we need to know the etiology. Most of us know the etiology or how it starts, but I would just want to refresh some of your memory. The etiology of it is, first of all, you have to have two important key products. You have to have pathogenic bacteria, right? That's your F. nucleatum, your P. gingivalis, your A. actinomycetin comitans, your, all your trypanomas, your spirochetes. You need to have these guys, right? But they have to have a host. You have a susceptible host that is your patient with sulcus or sulci, right? Because that's where they're going to inhabit. So you have about 50 to 80% of the population that has the periodontal disease. So is it all a genetic mutation, or is it really an obliging host? It's a host that has comorbidities, that has a lot of diseases, has a lot of suppressed immune systems, and those suppressed immune systems are coming from multiple factors. And we're going to talk a little bit about that later. So if you have an obliging host, you're going to get an immune response. So it's really not the bacteria that is causing the breakdown. It's that immune response to the bacteria. So if you have a strong immune system, and you're healthy as a horse, you can have bad bacteria, but you're not going to really, or as Dr. Kennedy likes to say, you're bad bugs. Got to give him homage. Your body's not going to respond as strongly as it would as if you're compromised. And we see that a lot. A lot of the patients we have are very sick. A lot of patients come to us who have cancer, which I just beat ovarian cancer. Thank you very much. Yeah. I don't want to cry. That's why we have our little hat on today. But yeah, so a lot of patients come to us sick. And so we need to make sure we treat them systemically, okay? Not just between the nose and the chin. So that immune response causes the breakdown of connective tissue and creates the bone loss that we see. Now, a lot of times in conventional offices, we take our x-rays and we see the crestal loss or we see the vertical bone loss, and we tell the patients they have periodontal disease. We do the probings, they have probing depths, 5 to 9 millimeters, et cetera. That's where you got periodontal disease. And they treat the disease. They're not preventing a disease. They're just continuing to treat a system that needs to be stopped. And that's what we're going to talk about more. So the biofilm is what's causing it. The soupy matrix, okay? It's not necessarily the calculus. So I'm talking to a room with hygienists saying you don't have to remove every speck of calculus. Don't attack me. I know. I'm one that has to remove every speck of calculus. My office manager will tell you when I'm running late on patients, when I used to practice clinically, well, are you done yet? No, I got to get that last piece of calculus. Yeah, it's not the calculus, it's the biofilm. It's that soupy matrix, because a bacteria by itself, in and of itself, it has the makeup of causing an inflammatory response or initiating that inflammatory response, but they like friends. They like to be in the pool with other ones. They like to aggregate. So a lot of the bacteria, once they're with other ones, they're going to start to party harder, okay? So they're going to be more, just like if you go out by yourself, you're a little shy. But when you go out with your friends, all of a sudden you feel a little, so you get a little more, virulent. So that's what happens. So when that biofilm starts to become more mature, that's when you're going to get a bigger problem. So it's about the biofilm. So they're able to protect themselves because they have our friends to protect them. So biofilm grows at a very high, fast rate. And that's something that we have to pay attention to, because we can do as much scaling and replaning, a beautiful prophy on our patient, the minute they walk out of the office, it starts all over again. So residual calculus, and again, I am by no means saying that you don't have to remove the calculus. Of course you do. But do we spend that much time on the calculus, or making sure that biofilm is reduced and making sure the patient knows how to do it at home? The speed of that biofilm reproduction is so quick. That's why it's important you need to review it with them. Within minutes, you finish your hygiene appointment and you polish with your fluoride-free, additive-free prophy paste. They get out of the chair, make their next appointment at the front desk. They already have quite a pellicle. They have that protein layer on the teeth. Within an hour, they're going to have 60 to 90% of the surfaces are already inhabited by the bad bugs. So all that hard work that you've just done is now starting to be undone. After an hour, 2 hours later, you have your actinomycetin is starting to grow. Those are one of your bad actors, along with PG and all the other ones. So it's important that patients know when they're getting home, just because you had a cleaning now doesn't mean you don't have to brush tonight, okay? 6 hours later, you're going to have a fully mature anaerobic biofilm. That's going to include your spirochetes, your Treponema denticola, Treponema forsyth, your F nucleatums, your P. gingivalis, and your S. aureolis. So you need to make sure that they fully are aware what to do. So because we know that this accumulates so quickly, do we worry about that one tiny piece of calculus, or do we spend the time making sure that they know how to disrupt it? Reviewing home care, whether it be using a water pick with medicaments like a mix of peroxide and water, or do we have them get a oxygen unit off one of those internet companies where they can make ozone at home and use water pick and use ozone at home, making sure they're using their floss and their interdental brushes and proper brushing technique. It's important that they realize this, because it's extremely important, because you're going to see a little bit in a study. Calculus, the effect on bleeding on probing, brushing is actually sometimes more helpful than all that scaling. They did a study, and this shows that I have a patient, they did an hour of scaling and root planing, and they did toothbrushing instructions. The bleeding sites went from 63 to 34%. Not bad, okay? Here you had a patient that they only showed them how to properly do home care. Statistically, no difference. Calculus is basically inert. Yes, it's going to impede the reattachment. If you're doing scaling root planing, you want to get that long junctional epithelium to reattach, so the calculus will impede that. But here you can see just the disruption of the biofilm is extremely important. Am I beating you over the head with this enough? Okay, because remember, I graduated in 1984. Back then, it was like removing every speck of calculus. They did not talk about biofilm at all. So, you know, the paradigm shift is so great. That's why I can't emphasize it enough. Okay. Brushing was as effective, which I already said. Scaling removes the calculus, which is basically biologically inert, which, you know, I just stated. And it removes the pathogenic biofilms that initiate that inflammatory response. So, what does that mean? The traditional periodontal therapy, there's no okay, that's chemo brain for you. Microbiological endpoint, because you're removing calculus. You're not eliminating the pathogens. You're not using the right therapeutic agents and the right targets. And you're focusing on the calculus removal, and you're doing gum amputation. I don't call it pocket reduction, I call it gum amputation, because you're removing body parts that could potentially be healthy. And you'll see at the end of my talk why I feel so strongly about it. And I used to be, while I was still in hygiene school, I was the surgical assistant to a postgraduate professor of periodontics, and I was also his surgical coordinator. So I was brought up with the conventional cut and sew, pocket elimination. I am 130, 180, 30, 130, 360 degree shift on that thought. So what is the average success rate on your scaling and root planing patients? Here they did a study, 57 patients. They did a full mouth scaling root planing. They monitored the patients for 3, 6, 9 months. And you can see here, statistically, there wasn't that much of a difference, okay? That's just mechanical debridement alone, okay? This is not with the modalities I'm going to talk to you about. Gingival redness, again, you're bleeding on probing, reduction. Again, they follow them 3, 6, and 9 months. Statistically, not much of a difference, because they didn't address the biofilm. Very unimpressive. So your limitations is you can't get to some of these crevices that are deep, because when you have your furcations, your bifurcations, your trifurcations, so there's certain access areas. You can scale until the cows come home. You're not going to be able to get to it. Here you have 1 to 3 millimeter pocket. You can remove about 83% of the biofilm. If you have 3 to 5 millimeters, you can remove about 58% of your biofilm, figure about half of it. But if you have a pocket that is 5 millimeter plus, you're not getting any of that biofilm. You're getting very little bit of it. That's why when I talk to you later about how you're going to be able to get that with modalities that we do in biological dentistry. So your residual pathogens, like I said before, these are one of your bad actors, the actinomycetin comitans and the P. gingivalis, cannot be removed from that deep pocket alone, by mechanical means alone. They tend to increase even after scaling root planing. Well, that doesn't make any sense. Well, it does, because they feed off of blood. So when you're scaling root planing, there's an inflammatory response going on. You're going to get a lot of bleeding. So now they're going to proliferate, okay? So it's important to use the holistic modalities as opposed to just conventional ones. Pocket depth misconceptions. Like I said before, pocket is not the disease. It's the sequela. It's not the cause. You can have a deep pocket that has no pathogens in it. It's considered healthy, quote unquote. By the time his pocket is measurable, of course, the bone is already lost. So wouldn't you want to address it before? You know, why am I treating or monitoring a disease process? I want to treat it before it becomes a sequelae or a reaction to that inflammatory response. Shallow sites are not protective. You can do that gum amputation. You can have shallow sulci. Guess what? They're going to be repopulated with all those bad actors, and you're going to start all over again. Like I said, deep pockets can be safe. So traditional periotherapy, this is just a recap of what I was discussing. If do the scaling rule planning, it doesn't work, you do more quad scaling rule planning, and if that doesn't work, now you do systemic antibiotics. You know, the studies have been showing recently that we're overdosing our patients on antibiotics. In a biological practice, we're probably not using any or a negligible amount as it is, but a lot of patients are becoming antibiotic resistant. We're overprescribing, so why do we want to do that? And if that doesn't work, now we start doing a gubby amputation and trying to reduce the pocket depth, which is just going to get reinfected anyway. So the AAP research has shown that the periodontal disease is caused by the inflammatory reaction of the bacteria under the gum. So why are we not addressing it in a conventional practice? And that's where we make the difference. We do that. This one gets me really hot. Not just physically, but if they are not looking at the subgingival microflora, there is no endpoint of the therapy. So in my mind, they don't know what they don't know, and what happens is it just continues to perpetuate the disease. So the patients are never getting well. I want to find a way of getting that patient well and training them how to maintain them getting well. And they're the IAP saying it's really important to study it, but they're not promoting it. The position paper doesn't really say anything about how we're addressing that bacteria in that microflora. Who here has a phase contrast microscope? I know you do. Excellent. Okay, well, we're going to have to fix that. You guys need a phase contrast microscope. I started working with one back in 1984. It was great, and that's when we had the tiny little TVs with the, the bubble screen, not the beautiful flat screen monitors we have now. And it's amazing when patients see the bacteria moving around. They're like, oh my God, it's now real to them. Now they understand what's going on. They see these spirochetes, they see the amoeba, you show them the white blood cells, you tell them white blood cells, those neutrophils, that's your body trying to fight an infection, okay? So we need to address that, because what's gonna happen is your periodontal disease is just gonna continue to perpetuate. I don't care how much I scale your teeth. If you're not addressing that, you're not curing your patient. So I'm gonna highly suggest that you consider getting a phase contrast microscope in your office. I don't have any affiliation with the company. You saw the logo on the other slides. So you can work with them very closely. I highly recommend it. Another thing that I really, really like that some offices aren't using is the salivary testing. I love the salivary testing because I can't see everything on the microscope. Like certain bacteria, I am not going to be able to see. Sometimes I'll see, I'm not practicing clinically so much anymore. But when I would see, oh, they're non-modal rods. But that non-modal rod could be an F nucleatum. I don't know. It's not moving, but it could be an F nucleatum, which is a bad guy. Or some of those little dots, they look like cocci, which are healthy bacteria. Those little dots could be S. oralis or a PG. So that's why I like the conjunction of using a salivary testing, not only because it will give me information that I can't always get from a phase contrast microscope, but I can actually quantify. You'll see in a minute what I'm talking about. I can quantify how well the patient is doing. You can have a patient, despite all your best efforts, with all kinds of medications, all kinds of, whether it be, holistic, of course, biological modalities, no matter what you do, they're just breaking down. I have one patient in my mind that he just keeps breaking down. So something like this would really, be very helpful. And one thing about it, it tells you what antibiotics to use, but you don't use the antibiotic. You use your own protocol, whatever protocols you're using in your practice, whether it be colloidal silver, you're reducing the pH, which we'll talk about a little bit later. You're using your natural antibiotics, your oregano, onion, garlic, any other Ayurvedic stuff that you're using in your practice. You use that to kill the bacteria. So what's great is that it also shows, depending on what the patient has, like if a patient has a cardiovascular risk, your patient's already a cardiovascular patient, and they have a lot of PG in F nucleatum and Actinomycetum comitans, you can show them that you have a lot of this bad stuff in your mouth. You really need to address that because you already have a risk factor. You already have a cardiovascular issue. And this is just going to perpetuate it and potentially put you in the hospital. So again, making it real for the patient, not just trying to show them on an x-ray and the patient's like has no idea what they're looking at. They know how to read an x-ray. So you're trying to show them, or you're using disclosing solution, that's showing them gram-positive supragingival plaque. That's not real. So showing stuff like this can really help a patient. Now, this is something I really like to follow up with a patient. You can do another test. You can see the top. It's too light in here, don't you see the laser pointer? You can see the top one is the original one, and then the follow-up. You can see how their number is reduced. It says here, 46%, almost 50%. That's quantifiable. I can say, well, all these things that you're doing and we're doing is actually working. So we're going to be able to help you be disease-free because I'm not here to continually treat you. I want you to be treated and just come for maintenance. So that's what's, using them together. Using a phase contrast and using the salivary diagnostics, I think, is extremely beneficial. And this is how easy it is. You just have them spit in a tube and send it off. That's it. Okay, here we go into the nitty-gritty of some things that you can do. I am not going to be giving you specific, like I said, I'm not going to give you specific protocol to follow. I'm not going to say, I'm not going to say do this, 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 but I'm going to introduce things to you that if you're not using in your practice, you need to think about introducing into your practice. And that is probiotics for oral health. And that I'm talking about it systemically and orally. I'm not just talking about taking, systemic or probiotics. So here you have some of the bacteria. Actually, I'm going to go back to that other slide. There was a study that showed, I look at my note because unfortunately, chemo brain. It showed that the oral probiotics can reduce the bleeding and probing and pocket depth significantly. That's why. So thank you. I wanted to see my note. So these are some of the common, there's actually a lot more, but these are the most common ones that you could be using to reduce inflammation, help with pocket depth. I'm just going to leave that up there. You can take a picture. They do make probiotics just for the mouth. They make them in gum form and lozenge form. So those are great to use. So those are what the patients are going to use at home because you can do in-office application also. I know some offices like Dr. Molica and all that, they do in-office application. You place it in the gum pocket. It's a great way to shift the paradigm because now you've just used a lot of ozone water and a lot of great stuff to flush out those pockets. You want to have the body repopulate a good bacteria. You want to kind of shift the balance. So getting that jump start of doing a subgingival application in your office, but then they need to follow up and do it on a daily basis at home because that way you're going to get the most benefit because in the mouth, we're using it constantly, right? So it's going to deplete very quickly. So that in-office application is great, but you need to follow up on a daily basis to get the most benefit out of it. Also, prebiotics, really good. Going back to probiotic foods, you want to talk about things like kombucha, kefir, yogurts. Most of us, shaking heads, so pretty much what's that is. So making sure they're including in their diet, not just taking a supplement. Prebiotics are a lot of your fiber-rich foods. Prebiotics are great to feed your good bacteria. So if a patient they're like, nah, you got some bad bacteria, you got some good bacteria. If you do prebiotics, you're going to be able to feed that good bacteria. If your immune system is fairly good, because you're enhancing it with your other protocols, you're going to be able to overcome the bad bacteria. So you're feeding your good bacteria with the prebiotics. They have toothpastes, just enriching your diet with prebiotic foods. I don't want to make a lot of recommendations. I am not a certified nutritionist, apparently. So I would highly, highly, highly recommend, if you're going to be doing any of these things, that you're working with your holistic practitioners. You have an association with your naturopaths, your nutritionists. You even have a nutritionist come in the office. I personally work with an integrative nutritionist who's based in Washington State. I do everything by Zoom. I love it. So for personal reasons. So she's helping me by Zoom. So making sure that you're having a nutritionist who's specifically taking your patient's needs into consideration. So these are some of the recommendations, general recommendations for the probiotics. So now they're not doing this in a conventional office because you want to make that shift. Just make sure everybody has their pictures. Okay. Here's a study that's showing that within the limitations of this study that showed that the L-reuteri with scaling wound planing patient got a really great short-term response. Again, short-term because it was only a short-term application, so they need to follow up with that. So that's probiotics. If you're not using them in your office, you need to start doing that. Occlusal forces. Who here, I'm talking to hygienists now, I'm not talking to the doctors. Hygienists, are you checking your patient's occlusion? We're going to change that today. The occlusal forces are so important, and it's okay. I know we have a short amount of time. It always feels like we never have enough time when we're treating our patient, right? And there's so many things to do, but we have to try to really remember that patient. We want to get them well. So we have to try to figure out how we can figure these things into our appointment. Occlusal forces. If you have a patient who has any kind of interferences, any where they're hitting too hard, or any kind of occlusal that needs equilibration, you're going to have an increased risk of having periodontal breakdown. If the patient has pathogenic bacteria, already they have inflammatory response going on, and you add the fact that they're banging the heck out of their teeth, just like if you had a post in the ground and you keep kicking it, eventually it's going to start getting loose, right? That post is going to get loose. So now that bad bacteria is in that space, it's going to grow. It's a cycle, all right? So you need to be checking your occlusal forces in your patients. Here are some signs. I'm sure we all know the signs and symptoms of occlusal trauma. You can see it's like a puzzle piece. And these crazed lines, again, my thing doesn't work. Your crazed lines, if I don't necessarily even see the wear, the incisal wear, if I'm seeing the crazed lines, I know the patients are banging their teeth together. All right, so it's important that hygienists are checking that because now you're co-diagnosing along with your doctor. Okay, don't wait for the doctor to do all the diagnosing because we're an integral part of patient care. We're not just prophy queens, we're not just removing junk off people's teeth. We are healthcare providers. And by doing these things, you are going to make yourself very valuable to your patient, number one, and to your practice. But number one is your patient. Here's some more signs. Of course, the incisal wear, and you have the scalloping of the tongue. Your wear facet. Intraoral camera, take pictures of your wear facets with your intraoral cameras. This way the patients can see exactly what's going on. Seeing is believing. That goes back with your phase contrast microscope. Seeing is believing, right? And again, even as early signs as that tiny little bit of incisal wear there is enough for me to raise a flag and talk to my patient about their bruxing, grinding, maybe needing an occlusal adjustment. If you have a patient who is going to be in active periodontal treatment, I believe that it is imperative that you include as part of the treatment, not just your scaling and wound planing appointments, an occlusal evaluation must be part of it. Reducing any interferences or any high spots is going to make the success of your scaling and wound planing far superior. You're looking at the x-rays and you see the widening of the PDL. Okay, there's another sign that patients are grinding and clenching. Or if they're not grinding and clenching, the teeth are misaligned so significantly that their breakdown is going to happen. Now, this is a little quick video that checks for Fremitus. I check Fremitus, well, again, it's like I'm still practicing, but when I check Fremitus on patients, if I'm scaling and I see something moving slightly, because I have a tendency to be very hands-on when I'm working in a patient's mouth. I'm not just, I'm like, my hands are in there, like I'm climbing in there. And if I feel the slightest tiny little bit of movement, I'm checking for Fremitus. I'm checking the mobility because I'm like, okay, something's going on. Either the periodontal ligament is inflamed or something, so I'm checking it. This is a video on how to check for Fremitus.
A tooth with Fremitus has excess vibration of the tooth due to premature occlusal contact. Often it will have some mobility along with it as well. This is a test for Fremitus, and it's usually done when a patient reports hitting high in a tooth for no apparent reason. And it will be done along with an occlusal analysis and adjustment by the dentist. So to determine whether a tooth has Fremitus, sit the patient upright and stabilize the patient's head parallel with the floor. And then you're going to press your index finger on the cervical third of each maxillary tooth, starting with the most posterior tooth, moving forward tooth by tooth throughout the arch. On each tooth, have the patient tap their teeth together with their regular bite. Then note any teeth where actual movement is felt, and you can actually use a table to determine the degree of Fremitus, as shown here.
Okay. I do it a little faster than that because that's going to take too darn long because, again, we have enough stuff to do in our appointment. I take my 2 fingers, like a U, and I don't jam them in there, but I just get in there. Well, I kind of do. I get them in there, and I just have the patient continually just keep tapping their teeth. And I run my fingers. I keep running my fingers. And then the ones that I feel, okay, I feel more movement on that tooth, I make a note of it mentally, or I quick write it down, depending on if I'm having chemo brain that day or not. I keep going, and I make a note of which teeth have Fremitus, and I make sure the doctor is aware when they come in. He said, "Doctor, I'm very concerned about patients' periodontal condition and the fact that they're also hitting very heavily on tooth number 8, and I think that's something that you need to address. I would like to see if so you're empowering the doctor, and you're saying it in front of the patient. They're like, okay, yeah, it sounds like she kind of knows what she's doing, and and when the doctor says, oh yeah, I see that, it's you're getting 2 people saying yes, it's a problem. I would probably, if you do find areas of Fremitus or movement of the teeth, I would probably suggest to appoint a separate appointment for occlusal equilibration. I made the mistake of showing the doctor once. Patient had significant Fremitus on tooth number 8. And yeah, we went down that rabbit hole. I had him adjust number 8. And the patient's like, oh my God, this feels great. This hasn't felt this good in years. He said, but now I'm hitting here. And so it totally threw everything off. So he wound up having to do all kinds of adjustments because for years she was only hitting in the front. So yes, that's going to heal, but you have to. So I would make sure you has a separate appointment with the doctor for occlusal equilibration. So again, this just goes over occlusal trauma and why it's important to check with your perio patients. Again, in conventional offices, they're just diagnosing disease, scaling, replaning, and sending them on their way with a prescription mouthwash. Oxidative stress and periodontal disease. Oxidative stress, everybody in this room has it. Because first of all, it happens naturally, okay? But second of all, just living in, well, it depends on, I live in New Jersey, so I am definitely full of oxidative stress because it's one of the most industrialized states in the Union. A lot of junk in the air and the water and the food, et cetera, et cetera. So oxidative stress is basically a bunch of free radicals. Free radicals are molecules that are floating around that have an extra electron, and they cause a lot of damage. So that extra electron doesn't know what to do with itself. So that's why antioxidants are great, because the antioxidants give up an electron to that extra electron, and that's why everything now is happy. But if you have a lot of these free radicals roaming around, it's causing a lot of breakdown in the body. Now, when you're talking about periodontitis, the pathogens are activating the neutrophils, or your white blood cells, your army to fight infection, right? So now your white blood cells are activated, and they liberate a reactive oxygen species, okay? So now all this stuff is floating around in the body. And the antioxidants that the body naturally produces is not enough to counteract. So that's where, if you have a patient, I'd say most patients are, if not every single one of them, have a lot of additional oxidative stress. So that's why incorporating antioxidants. Again, it's about patient selection. I'm not saying every patient you need to throw everything but the kitchen sink at them. And this is something I was taught in school. You talk to your patients about lifestyle, their diet, environmental, are they drinking bottled water or is it tap water, or, is it processed foods or you're eating more organic? And, we're going to talk about nutritional counseling later about that. But again, a lot of it is lifestyle, and it's important to maybe pay more attention to the oxidative stress. You can see here in this little schematic, you have inflammatory factors. That's your prepackaged mac and cheese, your blue box mac and cheese. Creating oxidative stress. You're living in an environment that has a lot of pollution. They're breathing that in, your tainted water. So again, it's going to create the oxidative stress, and it's going to cause tissue damage if nothing is done. You use your antioxidants. You're going to reduce your oxidative stress. You're going to reduce those free radicals in the body. Now, all of a sudden, your body is going to respond with a reduction in inflammation and reduce the severity of your periodontitis. Now, this is not the one thing. It's a multi-pronged approach, okay? Like I said, you're not going to throw everything at a patient, but you have to do patient selection. Say, well, this patient really could use a lot more antioxidants, and they could use a lot more probiotics, but I don't need to use this, that, or again, patient selection. Here's a study showing or suggesting that there is a significant reduction in periodontal disease when the oxidative stress was addressed. Up to following 4 months later, they used 8 micrograms of lycopene for 2 months, did that daily, and then up to 4 months later, the patient still had benefits of it. So again, this is something that really I think is important. Nutritional counseling. I was taught way back in the day, nutritional counseling was part. And it's not just telling the patient not to eat sugar. It's about making sure they're on an anti-inflammatory diet if they're full of inflammation periodontally. For those of you who choose to take Dr. Al Dannenberg's course later, I highly suggest it. I love that man. He's amazing periodontist. He firmly believes in the ancestral diet. And he lives it himself. He unfortunately has some challenges himself right now, but he makes sure his patients are on an anti-inflammatory diet, and that's one of those things that's gluten-free. And it's not the fancy, well, I'm going to be gluten-free because it's now a fad. No, it's a lifestyle that needs to be followed. So I'm going to leave that to him to talk to you about. So I'm not going to get too much into the depth, but again, nutritional counseling, anti-inflammatory diets. Your supplements. Studies have shown or suggested that low vitamin C, vitamin A, and vitamin E is extremely important because if they're low, you're more likely to have periodontal disease. They did one study showing that the lowest level of vitamin C, they had a 30% increase risk of having periodontal condition. Things like, believe it or not, green tea, which I've actually clinically have seen the difference. Patients who are drinking green tea, or you can take green tea supplements. Again, I don't say, well, Fran said, no, these are things that you need to, look more into for yourself. The green tea catechins have been found to be profoundly beneficial in inhibiting the growth of P. gingivalis, which is one of the bad guys, okay? So it has a lot of cytotoxic effects. So, and there's a lot of other supplementations that you can use. Again, that's for another course. pH is critical for the oral balance and, of course, your systemic balance. When you're acidic, you have a more higher increase risk of getting a disease, things like cancer, et cetera, et cetera. So they show that the pH and nutrients are the two main components that can descend you into disease. So that's why I was talking about diet and pH. Now, does anybody check pH in the mouth? Okay. Oh, good. I'm glad to see that. Because even though it can change within minutes, depending on what you're eating or, if you've been drinking enough water or not, even though it can change very quickly, those who tend to be more acidic, you're going to have a higher risk not only of cavities, but you're going to have an environment where it's going to be very conducive for your gram-negative bacteria. They're going to proliferate because they love to live in an acidic environment. So you can very easily, in fact, they've done studies that show that it's extremely beneficial to do chairside pH testing. here, for example, this one, a salivary pH can be used as a quick chairside diagnostic biomarker. So if you're not doing it, get those little pH strip tests. Okay, it's very easy. It takes seconds to do. What do you do for your patients in the office or at home to have them balance their pH? You can use things like aloe vera juice or aloe vera gel. You can use an oral alkaline cleanse. There are mouthwashes that you can get that the patients can use. Some of them actually have anti-inflammatory qualities in it. There's one that I know has turmeric in it also for the patients who have active periodontal disease. So it's like two different, there's one that just is to balance the pH, and the other, and the same company has also turmeric in it. It's very beneficial. They're on the floor, so if you want to check them out. But anyway, it really helps our patient balance the pH. And also a pH diet is really, really great. Okay, chlorhexidine and povidone iodine. Chlorhexidine, not only do I hate it because it accumulates a lot of supragingival calculus and staining, that's not my main concern. It's a fibrin inhibitor, fibroblast inhibitor. What it does is that you're having the patients rinse with it, and not only do they have, it's a prescription, but patients' fibrin clots, when you're doing all that scaling and root planing and you want to get that long junctional epithelium to reattach, it's not going to happen if you're using subgingival irrigation with the chlorhexidine, because it's going to inhibit that. In fact, they've done studies where they took an extracted tooth, they coated it with the chlorhexidine, and they put the fibrin on it, and it wouldn't stick. So what's happening is now you're not going to get that reattachment. So you're not going to get that pocket reduction. So now here's what happens is the pockets get repopulated with the bad actors. So it's just cyclical. It just doesn't stop. Okay? That's why I don't like the chlorhexidine. Povidone iodine, on the other hand, and again, you can't use this on everybody. Patient selection. I'm going to keep saying that. Within 15 to 30 seconds, it is a broad spectrum cytotoxic, kills everything. That's why they use it pre-surgical, right? So if you're not using povidone iodine on some of your patients for subgingival irrigation, wouldn't be a bad idea. Again, patient selection. If a patient is allergic to iodine, you cannot use that. If a patient is pregnant, you cannot use it. If they have thyroid condition, you cannot use it. Again, I want you to do your own research on top of this. I don't want you to say, well, Fran said. Here's another study showing and suggesting its benefits. And here's a long-term study. This one blew me out of the water, and I couldn't believe when I read this. Up to 13 years later, it reduces the prevalency of periodontal disease. So this can be definitely an alternative to the chlorhexidine, if anybody is using that. This is a way, if you want to take a picture of that, because I'm not going to go through it real quick, of how to use the povidone iodine subgingivally. Oopsie, all right. Let me know when you only because I want to make sure I stay on time. Okay. And of course, your dental ozone. Okay, that's pretty self-explanatory, right? Most of us are using ozone in our practice, right? You're using your ozonated water with your Cavitron, your ultrasonic. You're having patients rinse with your ozonated water. You have them use the ozonated water in their water pick at home, okay? Ozone is fabulous. When you're doing your scale and root planing, making sure your doctor or some hygienist can actually do the ozone injections. If you have a local anesthetic licensure, some states will allow hygienists to do the ozone injections. That's where you're going to get those deep pockets where it has the PGAA, like I said earlier. Like, how are you going to get to it? Your ozone injections, right? You're not going to get it any other way. So I believe this is how it happens. You have a nice strong oxygen molecule, you hit some source to it, and now you have 3 oxygen molecules as opposed to 2. And this is what's going to kill your bacteria, your viruses, your fungi, and your parasites. I don't need to beat this to death. A lot of people already know about the benefits of ozone. Most of us are already using it in our practices. Here, it's a study showing that it's how beneficial it is. Ozone trays are great. This is a great, I actually prefer biological offices to use ozone trays That's me, my personal preference, over the peroxide gel trays that everybody knows. I'm not going to say the name. I'm going to tell you why in a second. This is peroxide, and you have your, peroxide has been shown to be really, really great. You have your peroxide gel trays that are prescription, which is shown to be extremely effective. Up to about 9 millimeters subgingially, because the patient's wearing these gel trays on a nightly basis. They need to be compliant. That's one big problem. The biggest problem I find is if your patients still have amalgams in their mouth and they're using these peroxide trays, you're leaching all that mercury into a patient. Please do not have your patients use peroxide. Please, I beg you. So whether it be peroxide in the water pick or these gel trays, okay? It's important. There's another study showing how it's leaching all the mercury. So quickly, we're going to just review LANAP, which is a laser-assisted new attachment procedure. These are the patients that are far gone, and the scaling and planing are not going to help any longer. This patient, I probably, as a hygienist, before we even got to do the surgery, I would have talked to the patient about the mercury fillings if they're peritoneally involved, and they have all these mercury fillings. Don't tell me that that mercury did not potentially exacerbate or be a co-contributor to the periodontal disease, okay? So that's another thing. You see a patient has periodontal disease, they see all those mercury fillings in there. I'm going to talk to them about the importance of them moving him, not just because of the toxicity in general, but because it's actually, I see periodontal conditions. So I'm going to show this quick video.
This is the video animation of the FDA-cleared laser periodontal procedure called
Does everybody know what LANAP is?
New Attachment Procedure, or LANAP. The Perio fiber, about the size of 3 human hairs, is gently placed between the gum and teeth to remove the diseased tissue inside the pocket. This laser fiber selectively removes the diseased tissue and kills the germs that cause gum infections, while leaving healthy tissue unharmed.
You're not amputating gum tissue.
This also improves access and visibility for better removal of the barnacles of calculus from the surface of the teeth. Tiny ultrasonic root cleaners vibrate these deposits away and flush them out with antibacterial rinse. Once the surfaces of the teeth are clean, the laser is used a second time at the bottom of the pocket to remove any remaining debris and to sterilize the pocket, soft tissue, root, and bone. This also causes the blood to become sticky, creating a seal around the teeth. Once the seal is formed, we have created a clean, closed, and stable environment for healing to begin. We have tipped the scales in favor of regeneration versus degeneration.
So what's happening is that you didn't amputate any tissue. You have a deep pocket, you're cleaning it out, and you're causing that fibrin clot to be in there. And that fibrin clot is all your beautiful osteoblasts, right? So now your body is going to regenerate itself. That's why I drilled a hole in my doctor's head that he needed to incorporate this into his office, because you're now changing the paradigm of disease. Now you're reversing the disease process, and you're now causing your body to regenerate. What's more holistic than that? You're exciting the body to fix itself. And this is just a study showing that how beneficial it is. I'm going to briefly show some pictures. Here's somebody who had a tongue bar, and it created a huge defect, 12 millimeter pocket. It's a 22-year-old girl, very young. This is the day of, and 2 weeks postoperatively. Looks pretty good. Look at that bone fill, just by using that Nd:YAG laser. Here's a patient who had a defect on number 15, had a furcation involvement and a deep pocket on the distal. That furcation is now full, and the bone on the distal is now much better. Here's we have another patient. Here's a long follow-up. Now that tooth, how many would say that I'm going to extract that tooth? There's nothing there, all right? 6 years later, okay? Now, if it's hopeless, it's hopeless. I don't care what you can do. The lamp is not going to fix it. So, and then here, same thing with lip hip. This is with your implants. You can see that bone fill. Again, I'm going to stand in front of the computer because it's hard to tell what's what. Here's your bone defect. Look at the fill right there. Okay, here's another one, even though that's a terrible root canal. You can see the bone fill on that, mesial of that. I know I'm running short on time, so I'm kind of going through this a little quickly. This makes my heart bleed when I see this type of surgery, because with pinhole surgical technique, you can do this without being barbaric, using all these sutures, removing palatal tissue. I used to be, again, like I said, the surgical assistant, and I used to watch the surgery, and I would always cry because patients were always in agony and pain. So with pinhole surgery, does anybody know what pinhole surgical technique is? Everybody knows for the most part? Pinhole surgical technique, this is a quick video, I'm going to discuss it real fast, is your conventional therapy is you're taking a tissue from the palate, right? And then you're making this is your subepithelial connective tissue graft. And then you have to make a bed, you cut, you place it, you sew it on, patient's in agony, they're bleeding, I had a patient who came back a few hours later because the pain was so bad, he started drinking to kill the pain, and then of course the alcohol made him bleed more. It was impossible to get him to stop bleeding, it was just awful. So when the pinhole surgical technique was developed, I was like, this is fantastic. Because what they're doing is, they're using a proprietary instrument, they literally make a pinhole, tiny little hole, and they slip the instrument in there. They're detaching the attached gingiva. They're just kind of like moving it off the bone, periosteum, very simply. Just loosen it up, repositioning it into a place where it needs to go. So you're now redraping the tissue. And what happens after that, this needs to move a little bit quicker. Yeah, I'm going to stop very soon, I promise. You can see it's just repositioning. This is just too long. For those of you who have not seen it before, that's like, wow, this is great. I mean, I'm like, I know this already. So what now you do is through that little tiny hole, you're placing the collagen strips, and you're just holding it in place where the body is now going to absorb the collagen and replace it with its own. So now it's going to reattach. Some doctors I know even use fibrin clots. They do the PRF through that access hole, and they get that tissue to reattach. You can see how beautiful now, repositioned. Again, I'm just going to show you a few cases. 3 years later, you can see how nice. 3 years later, again, tissue is much better. You can see the defect on number 11. 9 years later, still great. And then here you have this one spot. I hate that bridge, but the tissue improvement is undoubtedly great. So those of you who are thinking about PST, I would highly recommend it in incorporating it into your practice. So to wrap it up, review your patient's medical history. Okay, make sure you are selecting the correct patient for the correct protocol. Work with your holistic practitioners, your naturopaths. If your doctor's a naturopath, awesome. It's, one-stop shop. If you have your herbalists, your nutritionists, it's important to work with them. The IAOMT, for those hygienists, the IAOMT offers mentorship, if you didn't know, not just for the doctors. I'm one of the mentors. So if you ever want to contact the IAOMT and you want to be assigned a mentor, let them know, they can always help you. And if you're not part of the IAOMT RDH Facebook page, you need to join it. Because right now it's being inundated by the doctors, so we need more hygienists on there, because we can actually talk about certain protocols. You have questions, we can collaborate, be able to help our patients more. So I want to thank you for spending your afternoon with me.